Can you guys hear me okay? Oh, perfect. If I stand over here, can you hear me? No. Okay. All right, we'll move over. Well, good afternoon. Thank you so much for joining me today. My name is Doris Deng, as Sherry said, and I'm currently an assistant clinical professor at UC Irvine. And it's a real privilege for me to be asked to speak today on treating women in epilepsy. So women with epilepsy experience unique challenges throughout various stages of life. And so we will explore a pretty broad range of topics during our talk today related to women-specific issues in epilepsy, from the neurobiology of sex hormones and their role in the pathophysiology and management of epilepsy, to reproductive health and aging. And finally, I will touch on the unique experiences of transgender women and men with epilepsy who may face additional challenges related to hormone therapy and gender-affirming care. My goal is to highlight the distinct needs of women with epilepsy and emphasize the importance of individualized care that not only considers the neurobiological aspects of the condition, but also the broader social context. So epilepsy, as I'm sure many of you know, is one of the most common neurological disorders worldwide and affects approximately 1% of the U.S. population. So overall, there's about 3 million people in the U.S. with epilepsy, and epilepsy affects men and women at about similar rates, and so there are about 1.5 million women with epilepsy in the U.S. alone. So one of the key themes that you'll see me talk a lot about today in our talk is the impact of sex hormones on women with epilepsy. In particular, estrogen and progesterone are the main players here, and estradiol and allopregnanolone are the bioactive forms of these sex hormones. And they exert their effects through excitatory and inhibitory neurotransmitters in the brain. So estrogen is known to increase neuronal excitability by enhancing excitatory neurotransmitter release in the brain, such as glutamate. This means that with increased levels of estrogen, such as during certain periods of the menstrual cycle or with hormone replacement therapy, there can be an increased risk for seizures. On the other hand, progesterone tends to have more of a protective, more anticonvulsant effect through modulation of GABA, which is the brain's main inhibitory neurotransmitter. So there's also a reciprocal effect between sex hormones and seizures. So not only can sex hormones affect seizures, but seizures can affect the neurohormonal axis. And so this connection between sex hormones and epilepsy is important, particularly when it comes to the effect of hormone fluctuations during the menstrual cycle, and as well as with interactions with anti-seizure medications. This dynamic between seizures and hormones is really the basis for catamenial epilepsy, which is defined as seizures that either occur exclusively during certain periods of the menstrual cycle or double in frequency during certain phases. Fun fact, catamenia is actually derived from the Greek word katamenios, which means monthly. And in ancient times, they actually thought that catamenia seizures were related to cycles of the moon. Catamenial epilepsy affects approximately 1/3 of women with epilepsy, but even without meeting the definition of doubling or seizures occurring exclusively during certain phases, 70% of women report some sort of worsening of their seizures with menstruation. So in catamenial epilepsy, seizures are affected by estrogen to progesterone ratios during the menstrual cycle. So the typical menstrual cycle is thought of as a 28-day cycle. Conventionally, day one of this 28-day cycle is marked by the first day of menstruation. This is followed by the follicular phase, which is when the egg starts to mature within the follicle, and there's an overall increase and rise in estrogen to progesterone ratios. Then this is followed by ovulation, which typically occurs around day 14. And then this goes into luteal phase, which is when the endometrium or the lining of the uterus thickens in preparation for pregnancy. And during this time, there's a gradual rise in progesterone levels. And then if pregnancy does not occur, progesterone and estrogen levels drop, and this is what results in sloughing of the endometrial lining or menstruation. So even though traditionally catamenial epilepsy is thought of as worsened seizures only around the time of menstruation, there's actually there's women who have seizures associated with other phases of the menstrual cycle. There are 3 distinct patterns of catamenial epilepsy based on seizure exacerbation during specific phases of the cycle when ratios of estrogen to progesterone are the highest. So in women who have normal menstrual cycles, we see the C1 and the C2 patterns. The C1 pattern is with women who have increased seizure frequency during menstruation, so the traditional definition of it. But we also see what we call a C2 pattern. And these are women who have increased seizure frequency during ovulation, so around days 11 to 14. Then over on the right here, we have a graph looking at menstrual cycle in women who might not get their period every month, or women who have anovulatory cycles. This is called the luteal pattern or C3 pattern. And in women with anovulatory cycles, there's no surge of progesterone during the luteal phase because ovulation does not occur. And so in other words, the estrogen to progesterone ratio remains relatively high. And these patients can have seizures during the menstrual, the luteal, and the ovulatory phases. So how does this affect the way that we manage seizures in these patients? I mentioned earlier that progesterone is shown to have an anticonvulsant or protective effect. So they did actually do a study looking at this called the progesterone treatment trial. This was a double-blind, randomized, placebo-controlled trial looking at natural progesterone supplements for the treatment of catamenial epilepsy. So this study recruited 294 women. And progesterone supplements were given to these women during days 14 through 28 of their menstrual cycle. And across all participants, there was no significant reduction in seizure frequency. However, when they did a post hoc subgroup analysis, they did find that women with a C1 pattern who had tripling of their seizures around their menstrual cycle showed a significant response in seizure reduction. So based on this study, one approach that we can do is to use natural progesterone supplement taper during days 14 to 28 in women who have the C1 pattern of catamenial epilepsy. It should be noted that these are natural progesterone supplements and not synthetic progestins. This effect actually has not been shown in studies looking at the use of progestin-only oral contraceptives for treatment of catamenial epilepsy. Other possible treatments include clobazam and acetazolamide, though these are not as well studied. There was a small double-blind study looking at clobazam, which showed some responsiveness with catamenial epilepsy. And then for acetazolamide, the evidence has largely been anecdotal. It was initially thought actually that it may reduce seizures based on its production of metabolic acidosis in our body, similar to the way that the ketogenic diet results in ketoacidosis, and so they thought that maybe this would have a similar effect. But studies looking at this have not really shown much difference. In women with the C3 pattern or who have irregular menses, the Depo-Provera shot may be helpful by suppressing menstruation. So it is very important for providers to counsel patients on contraception. I always make sure to ask my patients who are women of childbearing age whether or not they are on contraception, not only because of the risk of pregnancy, and how that might inform the anti-seizure medications that I choose, but also because of the interactions between oral contraceptive therapy and seizure medications. The rate of unplanned pregnancies in women with epilepsy is about 50%, so pretty similar to the general population. And oftentimes pregnancy is discovered at 6.5 weeks, which is during the period of organogenesis in the fetus, and after closure of the neural tube at 4 weeks. I want to emphasize this point because many anti-seizure medications that we use can be teratogenic. So in other words, they can lead to congenital malformations and adverse developmental outcomes with in utero exposure. So in general, we try to avoid teratogenic medications in all of our patients of childbearing potential. But it becomes extremely important to consider in patients who may be sexually active and do not use contraception. Even in patients who might not be sexually active and may be on birth control, for example, to help regulate their menses, it's important that the neurologist is aware of this because, like I mentioned, oral contraceptives can affect anti-seizure medications. So, for example, the estrogen in oral contraception can enhance the metabolism of lamotrigine and decrease lamotrigine levels in the blood. On the other hand, some of the medications that we use are what we call enzyme-inducing seizure medications like carbamazepine, phenytoin, phenobarbital, and these can all decrease the effectiveness of oral contraceptives, and these patients should be advised to use barrier protection as a backup. So this chart was taken from Continuum, which is a journal that we have in neurology, and it's a good guide for contraceptive options in women with epilepsy who are on anti-seizure medications. So the chart basically breaks it down into two major categories: options for those who are on enzyme-inducing seizure medications and those who are on non-enzyme-inducing medications. The seizure medications that have the biggest induction effects are carbamazepine, like I mentioned, phenytoin, phenobarbital, and then at high doses, medications like topiramate, oxcarbazepine, and perampanel can also have enzyme-inducing properties. So for those who are not on any enzyme-inducing ASMs, there are no restrictions to the type of birth control that they can use. So choose whichever method is best suited for the patient based on their lifestyle, their preferences, the side effects profile. Just keep in mind that if they are also on lamotrigine, that the estrogen in the oral contraception can decrease lamotrigine levels, so you just need to adjust the medication accordingly. OCPs can also decrease oxcarbazepine and valproate, but to a much smaller extent. For those who are on enzyme-inducing medications, the first choice would be an intrauterine device or an IUD, like the copper IUD, or a progestin-based IUD like Mirena or Skyla. The Depo-Provera injection is also an option. IUDs are the most effective and don't interact with ASMs because their hormonal effects are local as opposed to systemic. So Depo-Provera is also very effective, but its efficacy may be affected by strong inducers. The second choice would be things like implants, cervical rings, patches, like high-dose progestin pill or the mini pill, plus additional barrier contraception. If the morning after pill is needed for emergency contraception, just note that an additional dose may be needed after about 6 hours. When it comes to fertility, I think the big question that many patients have is, does epilepsy affect fertility, and is it safe for me to get pregnant? And the answer is complex and nuanced. There are many psychosocial factors that affect fertility in women with epilepsy. In women with epilepsy, this may be affected by things like the level of seizure control, their seizure medications, especially if they're on several ASMs, and the associated disability that may come with epilepsy, whether it's a comorbid condition like depression or anxiety, or the socioeconomic impact that epilepsy may have, like employment or social stigma. And women may also choose not to have children. In a UK survey, 1 of 3 women with epilepsy that they surveyed said that they did not want to have children because of epilepsy. And the most important reasons that they cited for this was their decision was related to the risk of epilepsy or seizure medications affecting their child, the effect of pregnancy on their seizure control, and the risk of their child developing epilepsy. And so this is why I think counseling on the part of providers is so incredibly important, as many of these concerns can be ameliorated or avoided with the correct counseling and by working closely with your neurologist and obstetrician. There was a study actually that was published in JAMA in 2018 that sought to answer this question of whether or not epilepsy has a direct impact on fertility. And so their question was whether or not there were any differences in fertility and birth outcomes in women with epilepsy versus women without epilepsy. The study didn't include patients who had a pre-existing history of infertility or any associated disorders that might cause infertility, like PCOS or severe endometriosis. Most of these patients were also on monotherapy. In other words, they were only on one seizure medication, and only about 10% of the women in the study were on more than one medication. And they found that there was no difference in how long it took for these women to become pregnant, their rate of ovulation, or their ability to successfully become pregnant. There was also no difference in miscarriage rates or live birth rates. So in other words, epilepsy in and of itself does not affect the ability of women to get pregnant, and most women with epilepsy are able to have healthy babies as those without epilepsy. For those women who have epilepsy and are struggling with infertility, assisted reproductive treatment is an option, but there's just some important factors that we need to consider when it comes to fertility treatments and IVF. So exogenous hormones that they use in fertility treatments to help with things like ovarian stimulation or endometrial preparation increase estrogen levels. And so this can impact seizure control both directly through the proconvulsant effects of estrogen and also indirectly through interactions with anti-seizure medications like lamotrigine. So if you remember, estrogen increases the metabolism of lamotrigine, which means that you can decrease lamotrigine levels in your blood. The good news is, however, that the chances of conceiving with assisted reproductive technology for women with epilepsy are similar to their peers. And this was demonstrated in a Danish study that looked at live birth rates in women who were receiving assisted reproductive technology treatments between 2006 and 2017. And there was no significant difference in birth rates between women with epilepsy and the control group. Furthermore, there didn't seem to be any significant difference in successful embryo transfer rates in women with epilepsy who were on anti-seizure medications versus those who had just recently discontinued their seizure medications. Of note, a lot of these women were mostly on just levetiracetam or lamotrigine monotherapy, but there was a small percentage of them who were also on things like Depakote or on multiple ASMs. And this study didn't find a difference between women who are on polytherapy, though the numbers were pretty small, and there have actually been some prior studies noting that polytherapy may increase the risk of infertility, so just to keep that in mind. So now, you or your patient have decided to become pregnant, and with that comes a whole host of other questions and concerns like, how will being pregnant affect my seizures? And if I do have seizures during pregnancy, what is the risk to the baby? And I think the big question that we see and that many people have is, how will my seizure medications affect my baby's development? And what do we do with my seizure medications now that I've decided I want to become pregnant? Well, hopefully I'll address some of these questions over the next several slides. The first question is, how will pregnancy affect my seizure control? There are many factors that can affect this potentially, one being hormonal changes. So it's no surprise that hormones may play a role here. During pregnancy, increases in the levels of estrogen and progesterone may impact seizure control. Physiologic changes. So when women become pregnant, our body goes through significant physiologic changes that, like for example, increased renal and hepatic metabolism, which can lower the levels of certain seizure meds. Another issue might be medication compliance, and this is usually due to the fear that many women have of the teratogenic effects of anti-seizure medications. And again, this is why it's so important to follow up with your neurologist or epileptologist for counseling. Sleep deprivation and stress, which are common seizure triggers, may also have a greater impact in pregnancy, and that's no surprise. The reassuring thing, though, is that overall, most women do not experience a change in their seizure control during pregnancy or when they become pregnant. The most important predictor for seizure control during pregnancy is their seizure control prior to pregnancy. Some other good news is that women with catamenial epilepsy may actually experience an improvement in seizure control during pregnancy. Women with the C1 pattern, like we talked about, who have seizures around the time of menstruation, are actually more than twice as likely to be seizure-free or have a significant reduction in their seizure frequency. So this graph that you see here is taken from a study looking at the seizure course during pregnancy that was published in Neurology Journal in 2014. They looked at 274 women with epilepsy. 59 of them had catamenial epilepsy, and those are represented by the blue bars, and 215 of them had non-catamenial epilepsy. And so you can see, even without seeing the numbers on the y-axis or looking at the categories below, that there was a significantly greater percentage of women with catamenial epilepsy who were either seizure-free, which is the bars that you see on your left, or had a significant reduction in their seizure frequency during pregnancy compared to those with non-catamenial epilepsy. When we look at the possible risks of seizures to the fetus, convulsive seizures or generalized tonic-clonic seizures carry the highest risk of fetal distress. In addition to the risk of trauma from convulsive seizures, these can not only result in hypoxia and changes in heart rate in the mother, but these effects can be seen also in the fetus. There's a lower risk with focal seizures. There are some case reports out there of women who had focal unaware seizures during their pregnancy and were shown to have a transient drop in the fetal heart rate. But they did note that these women delivered healthy children. There's also some evidence that seizures might affect verbal IQ and be associated with low birth rate. There's no direct association, however, of maternal seizures and congenital malformations. So one of the biggest, I think, concerns that many women with epilepsy have is the effect of their anti-seizure medications on the developing fetus. So many seizure meds, particularly some of the older seizure medications that we use, are teratogenic, meaning that exposure in utero can lead to fetal malformations and negatively affect fetal development. Valproate carries the highest risk of fetal malformations. There's a 10.3% rate of congenital malformations with valproate. And most commonly, we see this with neurotube defects, as well as cardiac, urogenital, and craniofacial malformations. And so in general, we try to avoid using valproate in women of childbearing age unless it's absolutely necessary for seizure control. In other words, they've failed everything else and it's really the only thing that works for them. Drugs like phenobarbital, phenytoin, and carbamazepine carry a more and topiramate carry more intermediate risk with about 4 to 6% rate of congenital malformations. Phenobarbital and carbamazepine can be associated with cardiac defects, whereas topiramate more commonly is associated with cleft lip and cleft palate. The medications with the lowest risk and the ones that we use most often in women of childbearing potential are levetiracetam, lamotrigine, and oxcarbazepine. This risk is also dose-related. So, in other words, the higher the dose, the higher the risk, and that includes with valproate as well. So the risk is also increased with polytherapy, but this is usually more due to the type of medication that they're on and not necessarily the overall number of medications. The ketogenic diet is also not currently recommended for pregnant women with epilepsy due to the potential effect on organogenesis. So many patients these days are actually on newer generations of ASMs like Keppra, ezocarbazepine, and lacosamide. Their safety in pregnancy and developmental outcomes has not been as well studied as some of these older medications, but there does seem to be some promising data that's come out recently for the safety of lacosamide in pregnancy. The most updated evidence came out of a European registry in 2023, which looked at 55 prospective and 10 retrospective lacosamide exposures in pregnancy. And they did not find any major fetal malformations or increased risk of spontaneous abortion with lacosamide. But overall, I would say that we need more data looking at these newer generation medications and their safety in pregnancy. And the best way to obtain this data is to encourage all eligible patients, so women who are pregnant and who are on seizure medications, to enroll in a pregnancy registry like the North American AED Pregnancy Registry. In addition to the potential for congenital malformations, ASM exposure in utero can also lead to adverse cognitive outcomes long term. More specifically, valproate exposure can have a negative impact across all cognitive domains, including verbal, nonverbal ability, memory, and executive function. And it's also associated with a higher rate of developing ADHD in the child. A big study called the MONAD study, which stands for Maternal Outcomes and Neurodevelopmental Effects of Anti-Epileptic Drugs, is a large prospective multi-center observational cohort study that's ongoing, and here in the US looking at cognitive outcomes across multiple domains in children of women with epilepsy. These women were mostly on levetiracetam and lamotrigine, with only about 1% of mothers on other seizure meds like oxcarbazepine, zonisamide, and topiramate. And they found that there was no overall difference in cognitive outcomes in children who were exposed to some of the newer generation anti-seizure meds when looking across all cognitive domains. But when they did a secondary analysis, they did show that there may be some exposure-dependent effects of Keppra or levetiracetam on some specific cognitive measures, specifically the verbal index score, which looks at naming and verbal comprehension. There are some cases, I've made valproate look like a bad guy here, but there are some cases in which valproate might be the only option. For example, a patient might have failed multiple other seizure meds, like I mentioned, and they've only really responded to Depakote. And some generalized epilepsies may also respond better to valproate. In these exceptional situations, the patient and the provider just really have to form a much more nuanced and tailored approach and really understand and weigh the risks and benefits. And this may involve trying to switch to an alternative ASM that they haven't been on before, or maybe going back and trying something that maybe they didn't tolerate as well and weighing the risks and benefits of those side effects, or lowering the dose of valproate. Because like I mentioned, the risk is dose-related. All women of childbearing potential who have epilepsy should be on folic acid supplementation. And they should be on at least 0.4 milligrams of folic acid daily and starting at least 3 months prior to conception. So whether or not patients plan on becoming pregnant, women with epilepsy of childbearing potential should be on folic acid supplementation, given that the risk of, like I mentioned, of unplanned pregnancy is about 50%. There has been a lot of debate in our field over what is the best dose of folic acid. And decades later, that debate is still ongoing. But currently, the CDC recommends 0.4 milligrams per day in all women of childbearing potential and 4 milligrams per day for women of higher risk. This is based on population studies that showed that a higher dose of folic acid supplementation at 4 milligrams per day is associated with an overall lower risk for neural tube defects in women of high risk. So women who've had prior pregnancies with congenital malformations or who have a family history of congenital malformations. However, the benefits of high-dose folic acid have not really panned out in studies that look specifically at women with epilepsy who are on seizure medications. And there have been some concerns that have come out recently in the literature that doses higher than 5 milligrams a day are associated with an increased risk of childhood cancer and cognitive impairment, but we need much more data on looking at this relationship. To date, there has not been sufficient data looking at these dose-related benefits of folic acid, and the optimal dose, like I mentioned, is unclear. But at the very minimum, all women should be on at least 0.4 milligrams and consider higher dose supplementation for women who are high risk. So once there are plans to become pregnant, seizure control and seizure medications should be optimized. A good general principle is that patients should be on the lowest, most effective dose of anti-seizure medication, and this pertains to all patients with epilepsy. This is just good medication stewardship. So consider whether or not your patient could be on monotherapy. For example, if they're on low to moderate doses of more than one seizure medication, consider whether or not you could just increase the dose of one and come off the other, so to go from 2 to 1 medication. Valproate, like I mentioned, should be avoided if possible. If a patient comes to you on valproate or you are on valproate and looking to become pregnant, consider whether maybe there's some other appropriate options to switch to that haven't been tried. In some patients with super well-controlled epilepsy, for example, if you haven't had seizures in 2 or more years and there's a low risk of recurrence, you might even consider coming off of seizure medications altogether. Aim for optimal seizure control prior to pregnancy. Remember, pre-pregnancy seizure control is the most important predictor for seizure control during pregnancy. And once you've settled on a good medication regimen, you've optimized your seizure control, we should draw baseline serum drug levels during the preconception period, and this will serve as a reference for serum drug levels throughout your pregnancy. This is because our bodies go through several physiologic changes during pregnancy, which can really impact serum drug levels. For example, blood volume changes. There's less overall albumin in your blood, which is the protein that's responsible for keeping fluid within your blood vessels. It's responsible for transporting things like drugs, vitamins, enzymes. In addition, there's an overall increase in blood volume during pregnancy to support the growing baby and maternal organs. And so together, this means that the level of drugs, especially those that are highly protein-bound like valproate and phenytoin, can decrease. In the first trimester, women might also have much more nausea and vomiting, which can affect drug absorption. And then during pregnancy, your kidneys and your liver go into overdrive. So increased renal metabolism can lead to decreased concentration of drugs that are metabolized through the kidneys, such as levetiracetam and topiramate. And then increased estrogen levels during pregnancy enhance a process called glucuronidation, which is responsible for clearance of hepatic drugs. So this means that serum levels of hepatically metabolized medications can decrease. And in particular, we worry about lamotrigine, which can see as much of a 50% drop during pregnancy. Because of all the physiologic changes that women's bodies go through and the fluctuations that they can experience in drug concentrations during pregnancy, guidelines recommend at least monthly monitoring of anti-seizure drug levels, particularly for those seizure meds that are impacted and susceptible to clearance changes like levetiracetam and lamotrigine, also topiramate, zonisamide, and oxcarbazepine. The goal is to maintain baseline levels. So in other words, levels that were hopefully gotten prior to pregnancy, or if not early on, a drop of more than 35% of your pre-pregnancy levels, because this has been shown to be associated with worsened seizure control. In addition to maintaining baseline concentrations, further adjustments should be made if there's an increase in seizures during pregnancy or if you're having side effects to your medications. If therapeutic drug monitoring is not feasible, so for example, if accessibility is an issue, then a dose increase of 30 to 50% should be considered after the first trimester if they're on a medication that's known to be effective during pregnancy. You should also consider an empiric increase in patients who are sensitive to changes in seizure medication levels, who maybe have a history of breakthrough seizures if they have missed a dose, or those who are on the lowest effective dose of their medication. So for example, if a patient comes to me looking to get pregnant and they're on Keppra 500 milligrams twice a day, which is the lowest effective dose for Keppra, I might consider going up on their dose to 750 milligrams twice a day. Drug monitoring should continue into the postpartum period, as all of the physiologic changes that you've experienced during pregnancy start to normalize over the next following weeks. You should start discussing a taper plan in the third trimester with your neurologist, as changes in some of the serum drug levels can occur almost immediately. And this is specifically with lamotrigine levels. We can see a pretty rapid rise in lamotrigine levels in the blood within like the next few days, basically postpartum. Hepatic enzymes take about 1 to 2 months to normalize, and so drugs like carbamazepine, which are metabolized through the liver, can actually be gradually tapered over the next 4 to 8 weeks. When it comes to breastfeeding, we have all heard that breast is best. And there are many, many benefits of breastfeeding for both mom and baby, including improved neurological outcomes, decreased rates of illness in baby. For mom, it can help with things like postpartum bleeding, weight loss in the postpartum period, as well as reduce the risk of breast and ovarian cancer. But what about for women with epilepsy? And are seizure medications transmitted through breast milk? And if so, is it safe to breastfeed? The short answer is yes. There has been a lot of data looking at the transmission of anti-seizure medications in breast milk. Drugs like valproate and carbamazepine, which is I think what most people worry about, are actually not transmitted in breast milk. And those that are, like Keppra and lamotrigine, are transmitted in very small amounts, almost inconsequential, either undetectable or subtherapeutic amounts. There is also no adverse cognitive or developmental outcomes in children who are breastfed by women with epilepsy. And in fact, analysis of data from the cognitive testing at 6 years of age in that NAIAD cohort that I mentioned earlier, which included mothers who were on phenytoin, valproate, and carbamazepine, actually demonstrated a benefit to breastfeeding. So children who were breastfed actually exhibited higher IQ and enhanced verbal abilities compared to the children who are not breastfed in women with epilepsy. So the consensus guidelines are that breastfeeding is not only safe, but is also recommended for women with epilepsy on anti-seizure medications. So anti-seizure medications get a lot of attention when it comes to pregnancy, and we've spent a lot of time talking about them. But one thing I think that gets often overlooked and can have a significant impact on childhood development is postpartum depression and anxiety. Postpartum depression, as defined by the DSM, is major depression that occurs in the 4 weeks following delivery. And depression is not always just feeling sad or down. It can manifest in various ways. It can affect sleep, whether it's sleeping too much, not sleeping enough. Patients may report decreased interest, low energy. They might endorse feelings of guilt or hopelessness. They can have changes in appetite or just report, impaired concentration and memory. Depression and anxiety are really common comorbidities that we see in patients with epilepsy, with higher rates compared to the general population, and this is also true for postpartum women with epilepsy. The signs and symptoms of depression can be very insidious, and patients might not recognize it, or they are ashamed to disclose it to their provider, so it's incredibly important that all patients are screened. Postpartum depression in general, regardless of epilepsy, has been shown to negatively affect socio-emotional childhood development. And these effects have been shown to extend into adolescence, which is why screening and early intervention are so crucial. New moms should also be counseled on postpartum seizure safety and precautions. Sleep is hard to come by with a newborn, but it's extremely important as sleep deprivation can be a seizure trigger. So we would recommend taking more of a shift approach, for example, having your partner or a family member do the feedings at night so that mom can get a good 4 to 6 hours of uninterrupted sleep. You can consider supplementing with formula or pumping in advance. Other safety precautions that we might not necessarily think about are things like not bathing the baby alone or not having the baby sleep in bed with the parents. When you're walking around the house, use a carrier or a stroller. If you're carrying them and you were to have a convulsive seizure, that would be a safety issue. And then consider feeding and changing the baby on a surface that sits low to the ground. Despite this, stress and sleep deprivation are almost unavoidable during the postpartum period, so it's always best to take a much more conservative approach to safety precautions. So we're going to fast forward a lot to menopause. Menopause is diagnosed after going 12 months without a menstrual period. Women with epilepsy may experience early menopause by about 3 years on average, and this has been shown to be correlated with overall seizure burden. The hallmark symptom of this period are hot flashes or night sweats. Later on in menopause, women may experience some vulval vaginal atrophy or thinning of the tissues in and around the vagina due to long-term estrogen deficiency, and this can lead to vaginal dryness or pain with intercourse. These symptoms are usually treated with hormonal therapies in the form of exogenous estrogen or a combination of estrogen and progesterone. So yes, our good old friend estrogen is back, and as we all know very well by now, I hope, estrogen may lower your seizure threshold and worsen seizures. So if possible, we do recommend talking to your gynecologist about using non-hormonal options like clonidine, which is a centrally acting medication, or topical treatments like lubricants. As we age, we all experience bone loss, men and women, but women in general have a much higher risk of osteoporosis than men just due to inherent differences in bone density and bone structure. In patients with epilepsy, this risk is then further increased with certain anti-seizure medications and with menopause due to decreased levels of estrogen. So induction of cytochrome P450 enzymes in the liver by medications like phenytoin, carbamazepine, and oxcarbazepine can increase vitamin D metabolism, which means that this would lead to lower levels of vitamin D and decreased calcium absorption. This can also be seen with non-inducing ASMs like valproate. So in general, we always recommend routine checking of your vitamin D levels, especially in patients who are on enzyme-inducing ASMs. You should be counseled on nutrition, exercise, and making sure you have adequate vitamin D intake with supplementation if needed. The typical recommended daily dose of vitamin D is 600 to 800 international units. You might consider doing a higher dose supplementation with something like 4,000 units daily if you're on enzyme-inducing medication. And finally, I do want to spend some time talking about transgender patients with epilepsy. We've discussed a lot about seizure management in women with epilepsy, which has largely centered on female-specific issues, as much of the research has focused on sex differences, but there's also a growing recognition of the unique challenges that are faced by transgender individuals in healthcare. So for many in the transgender community, access to healthcare is already a very complicated and sometimes harrowing experience, which can further be exacerbated by discrimination, poor social support, and a lack of knowledge and experience by providers in managing transgender-specific issues. Transgender patients with epilepsy face then an additional layer of difficulty as they navigate their condition and the additional social and psychological aspects that come with it. And so because this is a talk on women and epilepsy, I think it's really important to address some of these barriers today so that we can work towards providing equitable and gender-affirming care to our patients in the transgender community. One of the main considerations when caring for transgender patients with epilepsy is the potential for interactions between anti-seizure medications and sex hormones. Hormonal therapy in the form of exogenous estrogen or testosterone is usually used to help with the transitioning process. And so enzyme-inducing ASMs, like we talked about, can lower the levels of estrogen and lead to reversal of feminizing effects in trans women. In general, we also recommend using non-enzyme-inducing ASMs in trans women and avoiding things like valproate due to unwanted side effects like hair loss, hirsutism, which is male patterned growth due to excess testosterone, and weight gain, as Depakote can inhibit testosterone breakdown. Patients who do need to be on enzyme-inducing ASMs may need higher doses of exogenous hormones, but this needs to be weighed against the risks of thromboembolism and potential for worsened seizures. There's less of a concern with enzyme-inducing ASMs in trans men who are using exogenous testosterone as they don't have much of an interaction. But in trans men who have had catamenial epilepsy, they may actually experience some improvement in seizure control with suppression of menstruation. Lastly, there's an increased prevalence of HIV in the transgender community, and so providers should be aware as enzyme-inducing ASMs can lower the efficacy of antiretroviral therapy. Thank you, and I'll take any questions that you all might have. Thank you for sitting through the end of this talk with me. I'll open up the floor. Yes? To be honest, I'm not super familiar with that. I'll have to definitely look into that. Yeah. Yeah, no, that's a really good question. If you want, after this, I can give you my information and I can look that up for you and reach back out to you. Okay? Yes. Oh, sorry. Go ahead. Absolutely. Absolutely. Oh, great. Yeah. Yeah. Yeah, and epilepsy is not straightforward. And, even as providers, we don't always have the answers. And it comes down to, the individual and what their lifestyle, personal preferences, what they're willing to tolerate or not tolerate. So, yeah, I very much understand your struggle. Yes. Yeah, it's possible. It's possible. And so, like I mentioned, the traditional definition is a doubling of seizures during your during menstruation or during like ovulatory phases, or you only have seizures around that time period. But like I mentioned, outside of that definition, lots of women experience exacerbation of their seizures during certain phases of their menstrual cycle. It doesn't necessarily change a whole lot the way we manage it. The first line medications are still first line, but for example, in patients who might have very refractory catamenial epilepsy, then that's when we start to look at some of these other options, like I mentioned, like looking at natural progesterone supplements taking during the last 2 weeks. Clobazam might be a good option in that case. Let's see. Yes. And that's what makes it really hard. Yeah. No, that's a really good point. So I did mention, that when we looked at the progesterone treatment trial, right? These were women who had normal menstrual cycles, so very predictable, 28 days, and so that's why they're able to take the progesterone supplements during the last 2 weeks, days 14 to 28. But like I mentioned, there are women, who don't have regular menses or who have anovulatory cycles. And so I think clobazam in that situation might be a good choice. But not only just clobazam, if it's unpredictable, it's hard, like you said, to predict when I should even start taking this extra dose of clobazam. So if you tolerate it well, you might even consider just staying on the higher dose of clobazam. So. Yes. We get, as all women here, we understand that. That's okay. They're all the same. Yes, it can be. And so I don't know the exact rate of women with irregular menses, but I do see it very commonly in clinic. So yes, and a lot of those women, like I mentioned, can have those fluctuations with, with seizures and their menstrual cycle, regardless of whether or not it's double or only happens during menses. Yeah. Yes. Yeah, so it wouldn't necessarily affect seizures in terms of estrogen, progesterone, because that's more centrally secreted. As long as if you're talking about like a total like ovarian and uterine removal, then it may. And so then you speak closely with your gynecologist about whether or not a lot of these women have to be on some sort of hormone replacement therapy, and then. So these are the things that come into question when we talk about seizure control and things like that. So it could be, yes. May I ask ablation of? Okay. Yeah, so if we're talking about, removing the ovaries as well, possible if we're talking, if we're looking at, we're saying estrogen might increase seizures, but this also comes with the added risks, right? So now we've taken away the ovaries, and if you're young, that might lead to even longer term estrogen deficiency, which has its own sort of downstream effects like bone loss and things like that. And so some of these women may need, hormone replacement therapy at some point, or may need to be more closely monitored for vitamin D levels. So it's always risk and benefits essentially of that. But if you have really well-defined catamenial epilepsy, you've tried everything under the sun, that might be a consideration. But of course, after you sort of go through all of those risks and benefits. Yeah. Mm-hmm. 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 Yeah, that's so typically then those women will fall under the C3 category, right? Because some of those progestin IUDs also suppress ovulation, and it's sort of unpredictable when they're going to ovulate with that IUD. You can track it probably using like ovulation strips, which tell you sort of seizure patterns around that time. So that would probably be the only way, but that would be a lot of monitoring on your end. But usually in those women who stop having menstrual cycles, or like things with like the Depo-Provera shot, they tend to, in those women who have catamenial epilepsy, they tend to see an improvement. Yeah. All right. Well, thank you so much for coming. I hope you all took something away from this.